non-surgical management of persistent pain in workers' compensation, new trends and technologies. I'm Stephanie from WorkSafe Tasmania. In recognition of the deep history and culture of this island, we acknowledge Tasmanian Aboriginal people, the original and continuing custodians of the land, sea and sky. We acknowledge and pay our respects to all Tasmanian Aboriginal people, all of whom have survived invasion and dispossession and continue to maintain their identity, culture and Aboriginal rights. We now ask that you take a moment to read the following slide about information received today. To participate in today's webinar and ask today's presenters questions and provide comments, please use the chat window on your control panel. Those questions will be answered by today's presenters at the end of the webinar. Only presenter webcams will be used, and finally today's webinar is also being recorded. It is now my pleasure to introduce today's presenters, Alicia Bishop and Scott Bunton from IPAR. Alicia, a physiotherapist with a bachelor's in exercise science and a master's in physiotherapy, deeply understands pain and the latest research. Alicia became a pain coach after transitioning from private practice to occupational rehabilitation. She now leads the Rethinking Recovery program in Launceston, providing high-quality pain education and building connections with insurers, employers, and health professionals to improve client outcomes. Scott, an accredited exercise physiologist since 2019, is committed to improving his clients' health and wellbeing. Specialising in brain injuries, spinal injuries, stroke, soft tissue injuries and mental health, Scott focuses on enhancing quality of life and return to work outcomes. As a subject matter expert and pain coach for IPAR's Rethinking Recovery program in Hobart, Scott uses a biopsychosocial approach to pain management. And we welcome both Alicia and Scott to today's presentation.
Thanks very much, Stephanie, for that introduction, and thank you everybody for dialing into this webinar today. So as Stephanie was saying, I'm Alicia. I'm the team leader in the Hobart and the Launceston office for IPAR, and then I'm also joined by Scott, who's the team leader for IPAR in Hobart. We also wanted to start with a welcome to country, in that IPAR acknowledges the traditional custodians of the land upon which we live and work, and pays respect to elders past and present. We recognise that the health of our people is connected to the health of our planet. We value access and inclusion and seek to listen, learn and build strong partnerships. We aim to provide genuine opportunities for Aboriginal and Torres Strait Islander peoples within our workforce and throughout our business. Just if you're not familiar with IPAR, so we're an occupational rehabilitation provider that supports health, wellbeing and meaningful employment. So we mostly focus on return to work after an injury, but we also do lots of different services, particularly ergonomic assessments, functional capacity evaluations, and we support employers with injury prevention and wellbeing training as well. So in terms of today's topics, so we've got 5 main topics that we'll run through. I'll talk about the impact of persistent pain, so setting the scene for why we're talking about this really important topic. We'll move over to Scott, who'll give us some information on what the current research says about surgery, opioids and scans, specifically for persistent pain. Then I'll run through what the current clinical guidelines say that we actually should be doing for persistent pain. Scott will go through the Rethinking Recovery example of modern technology that uses pain education, that provides pain education using virtual reality. And then I'll come back and we'll give a bit of a summary and some final thoughts as to how we can all move in the right direction. So to get started with, so in terms of persistent pain, we can probably all agree it's a big problem. So it actually affects 1 in 5 Australians, which equates to about 3.4 million people in Australia. So if you haven't experienced persistent pain yourself, there's probably a chance that you might know somebody who is experiencing this. In terms of other conditions that it also affects, so 45% of people with persistent pain also experience depression and or anxiety, which is a massive topic, especially in today's workers' compensation settings. The financial burden on Australia is huge as well. So it sat at $144 billion in 2020, and that includes all the cost of treatment as well as time off of work and all the associated costs. And we're expecting that to increase to $215 billion by 2050. So definitely a big problem that we all need to be aware of as to how to manage. And then it certainly affects a lot of people who are working age. So 68% of people in Australia with persistent pain are actually of that working age bracket. And it's very common as well. So as I said, so 43% of people who experience any type of pain will actually live with it for more than 5 years. So it's a very common problem to experience. And it also increases the risk of plenty of other comorbidities that are up on the screen there. So just setting the scene, it's a very important topic, especially in the workers' compensation setting. So in that setting, it just adds more complexity to how we manage persistent pain. There's actually a study that was done in 1995, which is quite old, I know, but it has over 350 citations that compared the treatment efficacy between people who are on workers' compensation versus people who aren't on workers' compensation for the same type of treatment for the same injury. And they found that workers' compensation actually resulted in reduced treatment efficacy and greater pain overall. And so that's an incredible finding that they found back in 1995, which is still relevant in today's setting. Part of the reason why this could be is that the compensation settings tend to be biomedically driven. So we have to actually prove that you're injured in order to get the treatment that you need, which is just the nature of that setting, which can sort of exacerbate that persistent pain that people experience. And then we also have the psychosocial factors that make this situation more complex as well. So that could be a secondary psychological problem that people experience after their physical injury. We're also looking at different maybe workplace relationship breakdowns, which makes the journey to return to work quite challenging. And then there could be trauma associated with the original injury, which again makes that psychosocial factors a lot more complex. Especially in the compensation settings, we have an external locus of control. So what that means is the control tends to be taken away from the person who has the persistent pain, and it's put into the hands of their treaters. So they're told who to see, when to see them, which appointments to attend. They need to get their certificates every month, which is obviously part of the system and an incredibly important part, but that tends to take away the control from the person, and they feel like they no longer have control over their own recovery. So just setting the scene, it's a very complex issue, especially when we add workers' compensation on top of it. And then just to the right there, just throwing out this idea of calling it a compensation scheme versus possibly a recovery scheme. So the compensation word there tends to focus on being compensated for the injury. It tends to be that sort of backwards focus rather than the recovery scheme, which could be focusing more on recovering from the injury and moving forward. So in terms of what our current treatment trends are looking like at the moment, we're actually doing a lot more of those options on the left-hand side there in the red box. So we're seeing a lot of opioid prescription, a lot of scans and investigations, different imaging, a lot of surgery as well. And there tends to be this injury-specific focus for persistent pain. So the problem with this is it doesn't focus on the whole person, which is what we'll show in the presentation, that's where we actually need to be focusing treatment specifically for persistent pain. In terms of the statistics for how often we're using those treatments that are more passive, so we know that 70% of GP consultations for persistent pain actually result in a prescription of medication, and that's specifically for persistent pain. So that's a huge number of consultations. We also know that 13% of GP consultations, again for persistent pain, will result in an imaging referral. And if you think about persistent pain for lower back pain, which is possibly one of the most common ones, we know that you should only be referring for imaging if there's signs of serious pathology or red flags present. And statistically, we know that that's in less than 1% of lower back pain cases. So seeing referrals for imaging in 13% of GP consultations for chronic pain is a huge number. Again, what we should be seeing is more of this encouraging of the self-management exercises that the person should be doing and having this multidisciplinary approach which focuses on the person as a whole, looking at the psychosocial factors as well as the injury-specific treatment. And very importantly, the education piece should be there as well. When we're talking about multidisciplinary approach, we know that only 1 in 100 people who are experiencing persistent pain in today's society will actually receive true multidisciplinary care. And that looks like seeing the right treaters for getting the right treatment from those treaters, and all those treaters actually communicating with each other. So we need to start moving in the right direction.
Okay, thanks for that, Alicia, and welcome everyone. So let's have a close look at what the research says around surgery, opioids, and imaging. Okay, so an all too common treatment for chronic pain is the prescription of opioid-based medications. This includes things like codeine, morphine, oxycodone, and tapentadol, for example. There are a lot of well-known issues with opioids, such as the constant need to increase dosage and frequency over time as medication becomes less effective the longer it's used. The risk of dependence increases as well, which can cause an issue when it's time to stop taking the medication as people recover. It can lead to addiction in certain population groups and commonly causes nausea as well. But there are some lesser known issues with opioid use, particularly in the workers' compensation setting, that I wanted to highlight today. So did you know there's actually a vast amount of evidence showing that injured workers in a compensation scheme who have been prescribed opioids have worse outcomes to those who weren't prescribed opioids? So a recent systematic review investigated opioid use in the workers' compensation setting for spinal surgeries. So this was looking at things like lumbar surgeries and cervical surgeries. And it found that injured workers who were prescribed opioids prior to having surgery were 50% less likely to have a sustainable return to work, were 50% less likely to return to work within 1 year of surgery, had a delayed recovery, required extended time off work, had greater healthcare needs, and had greater cost to their claims. Additionally, when we look at the effectiveness of opioids for treating chronic lower back pain, for example, it's been shown that tapentadol has a failure rate of 90%, while oxycodone has a failure rate of 100%, showing that they don't lead to improvements in pain in most cases. However, they're still being prescribed as a primary treatment for chronic pain, despite the evidence of poor outcomes. In terms of imaging, so the research has shown, once again, in workers' compensation claims, when imaging is completed early, it tends to lead to a series of negative events. This includes increased rates of surgery, large and sustained medical costs, increased healthcare utilisation, prolonged disability, and a lower sense of well-being. Imaging for patients experiencing chronic pain is an example of a biomedical approach to treatment, which associates a physical abnormality or an injury with the cause of pain. And if we're looking at it from a chronic pain lens here, that's the outdated model of pain. Imaging often shows normal age-related changes, particularly in spinal scans, as Alicia mentioned earlier, which are occurring way too often as it is. But these changes include things like disc bulges and facet joint arthritis. These are normal changes that occur as we age and are extremely common in the general population. However, most of the time they're actually asymptomatic and don't cause any symptoms at all. But once a worker has an injury and undertakes a scan, these common and pre-existing changes are often blamed as the reason for the ongoing pain. So, for example, if we have a worker who has a lower back pain injury, goes through the workers' compensation claim, ends up receiving a spinal scan, and it identifies a L4, L5 disc bulge, this is often blamed as the cause of their lower back pain. However, it's probably pretty likely that this disc bulge was already there, it was already a pre-existing thing and may not be contributing to their symptoms at all. So this biomedical approach of relying on scans does not align with a modern evidence-based approach to pain, which should involve a biopsychosocial approach. When it is just a biomedical approach, it tends to lead to treatments such as surgeries and steroid injections to kind of fix the physical problem, but ignores the psychological and the sociological elements of pain. And therefore, pain tends to continue despite having these treatments. However, if we look at pain more holistically and approach it from a biopsychosocial focus, so looking at things like physiotherapy, psychology, and pain education all combined, it often results in a reduction of pain and the injury resolving without the need for invasive procedures. Okay, so next up is surgery. So when it comes to surgical interventions, as a treatment for chronic pain, there are two major issues here. Once again, if we look at it from a biological perspective only, undertaking surgery to resolve chronic pain is attributing the pain to a simple biological cause, and it's ignoring those other psychological and sociological factors, which we know influence pain as well, as I mentioned on the previous slide. And secondly, when we look at research for surgical interventions as a treatment for chronic pain specifically, surprisingly, there is very little research in this area. There's a lot of research into surgical procedures. However, only a small number of these studies actually assess pain as an outcome measure. And then of these studies that do assess pain, most research papers don't compare a surgical to a non-surgical group to determine which pathway is the most effective for chronic pain management. Most of the studies were kind of comparing like surgery A to surgery B and kind of figuring out which surgery type would be more beneficial. But if we're not actually having an effective control group that looks at a non-surgical option, like how do we know if surgery is actually the best option for our injured workers? So a recent review from 2020 by Professor Ian Harris, who is actually an orthopaedic surgeon. He led this study and he's based up in Sydney. They identified the 14 most common orthopaedic surgical procedures that are done for people in chronic pain or experiencing persistent pain. I've highlighted and underlined 4 of the most common ones that I see in my day-to-day work in the occupational rehab space. And unfortunately, these 4 particular surgeries, in my experience, tend to lead to poor outcomes, extended claims, ongoing pain, pretty regularly end up in whole person impairments and settlements rather than actually helping the person who's in pain. So still looking at the same data from this study here by Professor Harris, they compiled 6,734 randomized controlled trials or research papers, and of which only 64 of these papers actually had a surgical and a non-surgical group that they could compare. So it's actually less than 1% of all the papers that were found online could actually be used as part of this study. So when they did do the systematic review of these 64 papers, they found that 14% showed that there was a favourable outcome to surgery. However, 86% of these studies did not demonstrate surgery provided a better outcome. So not only is there limited research which compares surgical to non-surgical interventions for chronic pain, but there's also very little evidence that suggests that surgery is actually the most beneficial treatment for people in chronic pain, as 86% of these studies suggest that surgery is not the best option here. If we look at another study here in specifically a workers' compensation setting, they compared, once again, a surgical intervention here, but they were looking at a workers' comp setting versus a non-workers' comp setting. And it found that those who were in a workers' compensation setting were 4 times more likely to have worse outcomes, twice as likely to be unsatisfied with the surgery outcome, have high levels of pain post-surgery and during recovery, have high levels of disability post-surgery, their return to work was significantly delayed, and from an economic perspective, it led to higher costs to insurers as well as an economic burden to the injured worker as well. So in summary of the research around opioids, surgery and scans in a compensation setting, it typically leads to higher rates of opioid use, higher rates of imaging, higher rates of surgical interventions, and on average, significantly worse outcomes. But as Alicia mentioned earlier as well, the catch-22 is here in a workers' comp space. You have to prove the injury and prove that you need the treatment. So it's hard to get better when you constantly have to prove that you're injured in the first place.
Perfect. Thanks, Scott. So now that Scott's gone through a lot about what doesn't work and what we shouldn't be doing, let's have a bit of a look about what we actually should be doing with the current clinical guidelines. So this pyramid here was actually adapted from the Royal Australian College of General Practitioners. So they've developed this as a clinical framework for how we should actually be managing persistent pain. And the way this works is actually more of a structure rather than a linear process. So it's not like you start at step 1 and then move through and step 4 or 5 is the pinnacle. It's that you actually have to lay the foundations first. So any builders here, you would know that you can't start building the top story of a building until you have the foundations down pat. And then most importantly, those foundations stay there throughout the whole life of the building. So if we look at layer 1, it's the foundational management of persistent pain. So that looks like, first on that left-hand side there, you've got an effective therapeutic alliance, which is basically a fancy way of saying clinicians need to have a great relationship with the client. So a professional relationship, building that trust, letting the client know that you care about them and that you're learning their story, because we can't start providing any sort of treatment if we don't have that trust. Then we need to provide this education. So what we're talking about here is education about persistent pain. So if you understand something, you're going to be more able to manage that something. So providing that education right at the get-go, rather than maybe as an afterthought once the passive treatments haven't actually worked, we need to have the education first. Also in that foundational layer is also screening for red flags. So if we do find those red flags, that could be then again a sign of serious pathology, which, like I talked about at the start, that would be the less than 1% of lower back pain cases that would need a scan or an imaging referral or potential surgery. So screening for those straight up, making sure that's out of the way, and then we can focus on the whole person approach to persistent pain. Then we've also got that biopsychosocial approach again in that foundation layer. It shouldn't be an afterthought thinking about the psychological health of the patient once it becomes an issue. It should be addressed at the very start through there to make sure it has an effect ongoing. And then, of course, we need to be managing in a multidisciplinary team. So that looks as simple as referring to a physiotherapist, referring to another allied health professional, getting psychology on board as soon as it looks like something might be necessary, rather than waiting till it's too far down the track and it's desperately needed. So managing in that multidisciplinary team is one of the best clinical guidelines that we have for persistent pain as well. Once we've got that foundation right, we can then move on to layer 2, which is those lifestyle-based interventions or treatments. Again, thinking about the client is managing their own recovery through this whole process. So that's helping to, first of all, in the middle there, increase their physical activity. So that's where we do get them to do squats in the gym or go for a walk. We know that movement is one of the main antidotes for persistent pain. So that helps improve the pain, reduce it, helps train and retrain the body and the brain together. But if we think about just telling a person to do the squats or go for a walk without them understanding the education, without them having the right multidisciplinary team to prescribe that education, or without them trusting you as a health professional, we're not going to be able to get that outcome that we need from that physical education, that physical activity. Again, we've got that optimizing the psychosocial functions, so helping people understand that it's incredibly important to be connected socially with their friends and family, to be at work, because we know that that sense of adding to the community around you while at work is one of the best things that helps reduce the length of claims as well. But again, if they don't have that education that the pain that they're experiencing is not only related to their sore knee, then they won't understand the benefit of being at work or of going out with their friends or of spending time with family. We've also got improving the diet quality in there as well, which is something that just goes to show we're looking at the whole person. So making sure your general health is good, again, is another factor that influences persistent pain. So if your perception of your general health is poor, then your pain experience is going to be higher. So managing all those lifestyle-based treatments once we've got the foundations down pat. And then at the top here, don't think of this as the capstone, the pinnacle, the best treatment that we're all looking forward to doing. This is the last line of treatment if everything else is in place and maybe we just need that something extra. So this is that condition-specific treatment that Scott was talking about. So this could be some type of surgery, whether you need a total knee replacement, or that could be a cortisone injection to just, in the short term, settle down the inflammation that's raging on through the shoulder. So those treatments should only be looked at if everything else is down pat and working to some extent and you just need something extra on top. But again, like I said at the start, the other foundational layers should not cease if we do that condition-specific treatment. So keep this pyramid in your mind as we go through. We'll refer back to it a couple of times because it's the core foundation of those clinical guidelines for persistent pain. So in terms of what those clinical guidelines are, they're actually based on our modern understanding of pain. So if we rewind about 2 to 3 decades, we used to think that pain was only related to the structural change in a body part that was injured. We thought it was just that and nothing else. Therefore, the treatment just focused on fixing that injured body part. The problem came when people didn't fit into that category and they might have ongoing pain in the absence of serious structural pathology. And in that case, they'd either be put into 2 categories. They'd say, we must be missing something structural, and then you do repeat imaging, you do cortisone injections again and again. We go and do an invasive surgery, again with no outcome because we think there must be something structural that we've missed. Or the other category that people would be put in is that they're making the pain up, it's all in their head, they're going a bit crazy, and that didn't help anybody. Fast forward to now, we actually know that pain is always an experience that's created by the brain to protect a body part. So with that understanding in mind, it's way more holistic. It involves the whole pain system, which is the brain and the body, the whole person together. So treatment, therefore, should be focused on retraining that system and understanding the different biopsychosocial factors that are influencing that pain experience, rather than just magnifying into that specific body part that has had the original injury. So we talked about education a fair bit. Education is part of that foundational layer of the pyramid. And this is what we're understanding, that education about these understanding of how pain works is really critical to recovery. So let's look a little bit about how education make a difference. So if you've ever heard the saying that knowledge is power, that's what we're working towards here. So if people understand that pain is not always directly related to tissue damage, that can be a life-changing realization for somebody in persistent pain, because that's the difference between knowing that doing some activity and experiencing some pain is okay versus stopping every single time you get pain. So if people don't have this knowledge and understanding, again, they'll sort of fall into 2 different categories. One is where they won't push into pain at all, because if you push into pain, that means that it's dangerous, something's being damaged, so therefore it makes sense not to. That's if you don't have this understanding about how pain works. The other thing is people can end up in this category where they think it's up to them to recover, nothing's working, they just have to muscle through and push through the pain. But again, without the right knowledge and understanding behind the fact that that's actually a good thing to do to some extent, and that's how persistent pain is overcome, if they're just muscling through without the knowledge that that's safe, then that's actually going to lead to a flare-up, because they're understanding that that's actually dangerous, but they feel like they have to do it anyway. So that's where people get into this boom-bust cycle where they're constantly in a flare-up and then recovering and in a flare-up, and they get nowhere overall. So without this understanding, then the physical activity and the gradual overload just doesn't make sense. But knowledge is power, because when physical activity, think about that middle rung of that pyramid, when the physical activity is coupled with the right education, research has shown that people achieve much greater results. There's an analogy about a fish. So if you give somebody a fish, then you feed them for a day. But if you teach them how to fish, then you feed them for a lifetime. So that's the same thing here. If you give somebody the knowledge and skills they need, then they can take more control themselves, that's self-management, and they can help progress their own recovery. To think about how this works, if you were to give somebody just some squats to do, tell them to do 10 squats, but don't give them any context around why that's helpful and what the benefit of that will be, then that's unlikely going to be beneficial. They probably won't do it. And if they do, there's probably going to be next to no benefit. But if you explain to that person how pain works, why movement is safe and actually good for recovery, how it's normal and expected to maybe experience some increase in pain while doing that movement, then that can set them up for success because they have the knowledge behind the activity. So again, thinking back to that pyramid, building up that base layer before we add anything on top. So this is that basis of the non-surgical management for persistent pain, is giving the patients the tools, the education, the knowledge they need to help set themselves up for its success. We need to be moving away from those passive treatments that Scott was talking about and moving more towards those self-management strategies. So you can see on the right here, there's a forest plot. So this one was taken from a large meta-analysis in 2022 that looked at what interventions produce the largest and most sustainable improvements for chronic lower back pain. So they looked at over 13,000 patients across nearly 196 randomized control trials. And the forest plot that you're looking at there is the benefits of those interventions on the left compared to just physiotherapy care alone. So if the data point is on the 0, that means it's the same effect as having just physiotherapy care, which involves prescribing exercises mostly. If it's to the right of that middle line, it means it had a better effect than just physiotherapy care. And if it's to the left, it had a lesser effect. So to help you understand, the very last one there, no intervention, had a lesser effect than just physiotherapy care by itself. This one here, in terms of effect, is looking at reduction of pain intensity. They also looked at, in another forest plot, they looked at improvement of actual physical function. So those were the two outcome measures that they looked at. What they found, interestingly, is that there was a very similar effect between the second one down, which is cognitive behavioural therapy plus physiotherapy care, and also midway down there is PE, which is pain education and physiotherapy care. So both of those had a very similar effect, much better than just physiotherapy care alone. And that data point was taken at 2 months post-intervention. But then they also did further looking at the long-term effects, so up to 5 months and then up to 12 months post the intervention. And they found that far and beyond the other interventions, pain education plus physiotherapy care had the best outcome compared with just physiotherapy care alone and the other interventions, with both reduction of pain intensity and improvement of physical function. So this is huge, that when you actually add the pain education to the physiotherapy care, you have far and beyond much better effects and benefits. An interesting point to note as well, when they looked at the data up to 12 months post-intervention, they also found that just pain education by itself had a much greater benefit than just physiotherapy care by itself. But again, both of them combined together was the best outcome. So understanding why this actually works, we know that pain education builds pain-related self-efficacy. So if you haven't heard that before, that relates to a person who's in persistent pain, their confidence in their ability to do tasks, even while they're experiencing some pain, as well as their confidence in their ability to continue to progress those tasks. So if we provide pain education, if we reframe people's understanding of how pain works, then they have much better outcomes and can recover from persistent pain. So we know that education is helpful, but the next question is, how do we actually get that education right? So we know that we're not just computers where we can download a USB stick into another person's brain and hopefully everything's formatted correctly and they just get the right education in the right way. We know that's not how we work as human beings. So we can't just provide a blanketed approach. We have to be specific and individual to that person. We have to effectively communicate in a way that that person can understand, rather than in a way that we think they need to hear. So to do that, we can't just sit people down in a room with a PowerPoint slide and just rapid fire and hope that the right information sticks. We have to sit down one-on-one with the person, focusing on the important points, and then also doing less of a standardized approach. It needs to be a specific approach. So we know, as we've already understood, pain is affected by multiple different biopsychosocial factors. And obviously every human being is different. So those factors are going to be different for each individual. So it needs to be a conversational focus and understanding those factors so we can give the person the tools they need to modify those factors. On the right here is 8 different statements. So this was actually taken from a qualitative study in 2022. They surveyed 218 persistent pain patients who'd undergone research-based, evidence-based persistent pain education to 6, 12, and 18 months prior to the qualitative study being done. So they surveyed these people, figured out they actually had recovered. That's a key point. So it's not like they were still in persistent pain. These people, the education had worked and they'd recovered. And so the study surveyed these people and found out what they found were the most important points that stuck and that helped with their recovery. They collated all of that data and came out with these 8 key points here. And so that's really important information because that's a retrospective analysis of what has worked in real time with people recovering from persistent pain. What IPAR has done is we've taken those 8 statements along with lots of research and we've created an education program to help people with persistent pain.
Okay, so that's what I'm about to jump into now. So an example of a modern technology for those with persistent pain. So now that we know that we shouldn't be jumping straight into opioid prescriptions, referrals for scans and completing surgery as our first line of defense, which is really that top-down approach on the pyramid. And in fact, we should be looking at a bottom-up approach, so setting that foundation of a multidisciplinary biopsychosocial approach, including pain education. So at IPAR, in order to achieve this, we have developed a program called Rethinking Recovery, which helps people to understand their pain and empowers them to recover. So the Rethinking Recovery includes a structured virtual reality enhanced education and coaching program to help injured workers understand their persistent pain and develop strategies for making positive change to assist their recovery. The service complements other treatments that the injured worker might be undertaking as well. So whether that's with a physio or a psychologist, etc. And the idea is, we work towards a sustainable recovery and return to work process in line with the other treatment that they're getting as well. This program, it was developed through the world leading experts in pain science, including Professor Lorimer Moseley, and he also supports IPAR with some analysis of our program and the outcomes that we get. As you can see on the screen there as well on the left-hand side, we've received an award for this program up in Victoria in the bulk rehab sector. And this was due to our exceptional outcomes, accessibility and cost effectiveness of this program. And although this award was from Victoria, it's a national service that we offer, including down here in Tasmania. So you might be asking why use VR though, when we could just have an app or, flick someone some YouTube clips or some paper handouts to provide pain education. But when we look at the research behind VR, VR-based interventions, they provide an immersive experience that can't be matched by anything else. VR is a very simple yet very effective delivery tool, and it's been demonstrated in a systematic review from 2021 that VR can improve education outcomes by up to 50%. It allows the patients to be completely immersed in an environment where they can see and feel an analogy rather than us just trying to describe one and then imagining it. So, for example, in the Rethinking program that we have, there's a small part of it where the client will be standing on the edge of a cliff, and it looks very realistic. And it often gives people that uneasy feeling of being, at heights, as if they're there in real life. And this can open up a conversation around how our brain takes in all sorts of information, including from the environment that we're in. And the output is a physical response. And in this case, it's that fear of falling off a cliff. But in other situations, that response is pain. So it does really open up that conversation to pain education. Another systematic review looked into the benefits of using digital pain management programs, such as VR and Rethink and Recovery. And it found that for these interventions to be successful, they need to be individualized to the participant. We need to be making it relevant to the individual circumstances rather than a generic group-based session, which is what most pain education services are typically. It needs to focus on behaviour change strategies rather than reducing pain. So that's improving someone's functional interference index. It needs to have structured functional goals, and they need to be reviewed pretty regularly as well. We need to collaborate with the treating team, as I mentioned before, to make sure everyone's on the same page and delivering a consistent message. And overall, this is everything that we try to do in our Rethink and Recovery program. So just very briefly on what our program entails. So it's 8 sessions across 8 weeks. There's about a 10-minute component in the VR headset, and then about a 50-minute component where we sit down with the client and we discuss their education that they've just gone through and how it affects their life and their pain story. We come up with strategies for trialing different lifestyle changes and put a bit of a plan in place to implement over the coming week. And then when we catch up the following week, we sort of go through what worked, what didn't work. It's a bit of trial and error process, but overall it does lead to some pretty great outcomes. We keep insurers, treaters and employers up to date throughout. And we also included a GP case conference at the start and at the end of the program as well, where we try to keep it return to work focused when applicable, just to make sure we are progressing people along. So when we analysed the data from our first 128 participants to complete the Rethinking Recovery program, we found that on average, the functional interference index, which measures how much pain interferes with people's lives, that improved by 32%. Pain self-efficacy, which measures their confidence to manage their pain, that improved by 30%. Pain catastrophizing improved by 26%. Pain severity index, which is a direct measure of pain itself, that improved by 24%. And quality of life improved by 16%. And keep in mind here, this is only after 8 weeks, which is pretty impressive. The functional interference and self-efficacy, they were the most important outcomes that we wanted to see from our program. So improvements in self-efficacy, they're directly associated with reduced disability and an increase in the likelihood of returning to work, while improvements in the functional interference were associated with an increase in someone's ability to complete their work hours and their work duties. So yeah, that were the main 2 that we wanted to see improvements in, and that were the biggest improvements that we saw, which was great. This cohort of data also showed large improvements across all domains, and these outcomes were all statistically significant as well. But the most important thing here is that we are giving the locus of control back to the client, as Alicia mentioned earlier, and providing them with the skills and knowledge to positively influence their own pain and continue their own recovery. And obviously this takes a lot longer than 8 weeks. And we want to basically just give them the skills to be able to continue on their own. But you can see even just in 8 weeks' time, we can get some pretty great outcomes. So in Victoria, recently we completed a pilot with WorkSafe Victoria, where they compared the injured workers undertaking Rethinking Recovery as part of their recovery with IPAR, as opposed to those who didn't undertake the pain education program and just did their typical recovery. So, just attending physio and GP reviews and that sort of stuff. And it found that those who did complete the Rethinking program upgraded in work capacity twice as often, and also had achieved a sustainable return to work twice as often as well.
Alrighty, so now that we know the current clinical guidelines clearly encourage a non-surgical management of persistent pain, here's basically just a snapshot summary of what we've been talking about, of how we can ensure we are providing that evidence-based non-surgical management of persistent pain. So all of these things are on that, again, the bottom rung of that pyramid that we were talking about that describes the clinical guidelines. So making sure we have really good, robust pain education on board from the get-go. Programs such as Rethinking Recovery is what provides that, and making sure that's specific individual to the person and it's actually workable. It's not just a handout about how pain works and hoping that the person's taken that on. Next, we've got communication. That's not just between different treaters. That's not just between the employer and the insurer. That needs to be with everybody. So making sure the communication is open with the client specifically so that they can know what's happening, they're kept in the loop, and they feel more in control. Again, that internal locus of control, which is a great predictor of their recovery. So keeping communication going. Part of that is, again, that multidisciplinary team. That's where the communication should be. So making sure the referrals are happening from the early onset, from as soon as we realize persistent pain is what we're dealing with. We need to be sending off referrals to physiotherapy or exercise physiology, psychologists, whoever's relevant to help be along the journey with the client in managing their pain. We need to decrease that reliance on the passive treatment, which includes things such as rest, medication, surgery, all those things that Scott was talking about at the start there, including things such as massage, where you're relying on the treater to provide an input in their education, an input in the treatment, sorry. It needs to be that self-management, so it's an active recovery. Another thing here, when we're talking about workers' compensation, we need to be certifying based on capacity, certifying their capacity based on their ability rather than disability. So if they can't do their pre-injury role, that's okay. They might be able to do something. So whether they can sit for 10 minutes, whether they can walk for 10 minutes, putting down what they can do, because people can improve from something. It's very hard to improve from nothing. So making sure that we're looking at what people can do and focusing on that. Then that leads us into the occupational goals. So it might not be at the forefront of everyone's mind if somebody's got persistent pain to return to work, but it definitely should be. So unless that person is going to be never able to work again, we need to have those goals in place so that we can start making the right steps towards returning to the occupation that they want to. So that could involve making sure there's retraining available, or setting a goal as to what type of work they want to be involved in, helping apply for those roles, or just starting off with some suitable light duties, or making sure they have the right capacity. That leads us also into an early return to work. So that's not talking about returning as soon as possible to their high-level pre-injury role. That can lead to a flare-up. But we're talking about some sort of early return to work, which involves an early referral to somebody like IPOL, an occupational rehab provider, who can go about and figure out which duties are available, what's going to be suitable. That could involve doing a host placement so that they can build capacity in a less involved role to help step them back into their pre-injury role. That could also involve light duties, changing and modifying, working from home. So there's plenty of options rather than just sitting and saying we have no capacity and then trying to jump back into work. Again, making sure we have that biopsychosocial approach from the get-go. So we're not looking at just the knee that is injured, we're looking at the person who owns that knee. So looking at the person as a whole, making sure the person understands that persistent pain is related to all the biopsychosocial factors that influence that pain experience. And again, that comes back to that education piece. So helping the person understand that you're focusing on them as a whole and looking at those psychosocial factors as well. And then lastly, but certainly not the least, is the patient-centered care. So the person needs to be at the center of their recovery. They need to have that internal locus of control where people are providing them the support, education, and tools they need to recover. So as a final thought here, bit of a trick question for you all. Who's the expert on understanding the injured worker's pain? I hope you've all said the injured worker. We know that all those biopsychosocial factors that influence pain, the injured worker is the person who understands them best. but we need to set them up in the environment with the right education, the right people giving the right advice, and prescribing treatments that are actually going to bring out the understanding that they have of their own pain so they can help manage it. So this is a bit of a flow chart on the right here that just sort of summarizes the approach we need to adopt in order to follow those clinical guidelines with encouraging non-surgical management of persistent pain. So we need to provide the education from the get-go. We need to involve clients in their own recovery through the whole process. We need to give them control back, so focus on that internal locus of control, which has been shown to improve outcomes. And then we need to build their own self-motivation to recover. And that is high-value care. Yes, any questions for us?
All right, thank you to our presenters today, Scott and Alicia from IPAS. So if anyone does have any questions for our presenters, please use the chat window on your control panel to type and submit those questions. So just to start, Scott, you talked about 9 surgeries. What out of those 9 surgeries were found beneficial?
Yeah, cool. So I've got the research paper up on the screen here. So there was one study for a rotator cuff repair surgery. So there were 4 studies and one of them was beneficial. There was one study in a subacromial decompression, so one of 15 studies. For carpal tunnel decompression, there was 2 studies that found it was beneficial out of 8. For lumbar spine fusion, 2 studies were beneficial out of 9. For a total knee replacement for osteoarthritis specifically, 1 study was beneficial of 1 study, so that's actually a good outcome on that one. And lastly, for a knee arthroscopic procedure for osteoarthritis, there were 2 studies that showed a good outcome out of 8. So hopefully that answers that question.
All right, thank you. And then probably on to the next question, which you may have already answered in some capacity. Are there any studies on surgery to deal with neuropathic pain, for example, nerve ablation blocks?
Yeah, I'm sure that there would be. I guess the study we were looking at here was more around the orthopedic procedures rather than the neurological procedures. But at the end of the day, if we're looking at chronic pain, we need to be looking at it from a biopsychosocial perspective. So as long as we are, working through that pyramid that Alicia spoke through earlier, doing the pain education, getting that ground base level in, doing rehab, and if needed, potentially looking at surgery further down the track, then in that case, they might be beneficial. But yeah, as long as we're not just jumping straight into surgery as a first line of defense.
All right, thank you. And the next question is probably more of a comment. The concern I see is that even your presentation began with discussing medications, yet these seem to be the last thing considered as a possible issue by treatment providers and insurers. I feel this is the perfect opportunity for an independent pharmacist to have oversight on medications used before things get complicated further.
Yeah, exactly. It is the last thing that's considered and unfortunately has massive impacts on recovery. So yeah, I think having an independent person to oversee that would be great.
And I was going to add to that, that's part of that multidisciplinary approach as well. So having a pharmacist who obviously knows a huge amount about medications and where they should be used and how to wean off them if they have been used, because they are helpful in that short term. But yeah, getting the right people involved is going to be the most beneficial.
All right, thank you. Are you able to explain what CSL and BT is?
Yes, that's in that study with the forest plot. So CSL, all of them were psychological interventions with physiotherapy. So CSL was counselling, BT was behaviour therapy. So just showing when you combined any of those psychological interventions, one of which was obviously pain education, they had the cognitive behavioural therapy. When you combine them with physiotherapy, that physical intervention, they were looking at the outcome of which one was most beneficial compared to just physio.
All right, thank you. Are you able to explain again or tell us where rethinking recovery is available in Australia?
Yep, so literally everywhere in Australia. So IPAR is a national organisation. We have plenty of offices in both metro and regional areas. And we can also do a telehealth version of this now as well, where we physically post out the headset and we do like a Microsoft Teams sort of approach to it. So yeah, we can service the entire country.
All right, thank you. What are the exclusion criteria for pain education program via IPAR?
I can cover that one, Scott. So it's more about, I suppose, the inclusion criteria. So it's anybody who's experiencing pain for more than 3 months, which is where we clinically class it as chronic pain. And then especially if their pain is impacting their work and their function. In terms of exclusion, it's more of a case-by-case basis. So part of it is we've actually found the virtual reality, we thought there might be issues if people had vertigo or if they had felt claustrophobic in a space, but we've actually ruled that out because the virtual reality program doesn't move if you're not moving. So people who have got vertigo have used it before and been fine. We also can allow people to sit down if they feel a bit off balance rather than standing. And then in terms of the claustrophobic, it puts you in a space that makes it feel like you're in a wide open field. So you certainly don't feel closed in. In terms of other factors though, there might be some people who are undergoing significant social stress. They might not have the right mindset to be able to take on new information and education. They might be focusing on potentially psychological treatment for those secondary complications. So if that's the case, then we might delay the referral to that program so that it can have the most benefit at the right time. And another exclusion one might have been if they have really got difficulty with technology and they can't manage that themselves. But again, we talk them through that. All they have to do is just put on the headset. They don't need to be technologically inclined, just as long as we're there in person. But as Scott said, we've recently rolled out a telehealth version of this. So as I explained in the presentation, it's best to be one-on-one with the person specifically, but we do know that there are people who might be in a location that's very hard to access, such as in Alice Springs, but we'll now have a virtual delivery of the program where we'll actually post out a headset to them, provided they can help manage that themselves. We'll have an extra session just dedicated to helping them set it up, and then we can provide that service.
All right, thank you. Can you explain how you work with the primary treating medical practitioner?
Yeah, so at the start of the program, we would typically attend a GP review with the client. Typically, they're involved in a OC rehab setting anyway, so whether that's with IPAR or with another company. But we would typically go along, just figure out where they're at with their recovery, where they're at with their return to work, talk about the program and what we're going to cover. And then we do, I guess, the same sort of thing at the end to help the GP understand how the client has improved and what they're open to trialing and things like that. And that can obviously lead to improvements in their capacity and their ability to return to work. And from a allied health perspective as well, if we have physios and psychologists and whatnot on board as well, we keep them updated throughout as well. So identifying any issues that might be popping up from the client, as well as things that they're improving on and willing to try, particularly if we look at a rehab space, like as in a physical rehab space. Sometimes people are quite fear avoidant when they're in a lot of pain and they don't want to try anything, but we find that throughout the program, they become more open to trying rehab and getting back into, exercises in the gym with their physio or their EP. So just, keeping everyone up to date with where things are at, good or bad, and helping with improvements in rehab and capacity for work.
All right, thank you. Are you able to explain why recovery rates are worse with injured workers in the workers' compensation scheme compared with those outside of the scheme?
I can do that one, Scott, if you like. So As explained, I think I mentioned that study back in 1995, and then Scott had one specifically for surgery about in 2022. So those were the retrospective studies looking at the outcomes after the intervention was done. But we do know that the complexities are added when the compensation scheme is in place. So one of the major ones is taking away that locus of control from the person. So if somebody has that internal locus of control, they're managing their own recovery. It's up to them to get better. They might have had the injury doing some sort of personal activity, versus on workers' compensation, where you tend to have to, again, prove that you're injured in order to get treatment that you need. That can take away that locus of control and put it in the hands of all the other treaters. And so that can exacerbate that passive receipt of treatment rather than those self-management strategies, which again, clinically, we know those self-management strategies with that internal locus of control is actually what drives recovery from persistent pain. So that's possibly one of the biggest impacts when you're under workers' compensation. That's not something that can just be changed with the flick of a finger because of the way the system works. And there's lots of different things to cover off in that space. But we do know that to try and counteract that, we can follow those clinical guidelines to get the right people involved, try and give the person as much control as they can to help themselves recover.
All right, thank you. And then just to close with a final question, is the Rethinking Recovery Program viewed as a treatment by work cover?
Good question. In all states other than Victoria, no, it's not. It's considered an education tool, so it doesn't fall under treatment. In Victoria, it's a little bit touch and go at the moment. They're trying to work through that. In some eyes, it is a treatment, in others, it's not. So everywhere other than Victoria, it's not an issue. But yes, in Victoria, still working through that one at the moment.
All right, thank you. So that brings us, actually, hold on, one question just came through just as we were about to close. So are there any is there a holistic approach in Tasmania to aggregate clinicians, practitioners in one group so that those experiencing pain don't have to seek a never-ending list of medicos to help?
Yes, I'll jump in there on that one. So I guess if someone is in the workers' compensation space, typically you would end up with a rehab provider such as IPAR. And I guess the role of the rehab provider on that file would be to help collate information and get everyone on the same page and working towards a common goal. So I think that the rehab provider is that person really to get everyone together, rather than having all these individual people providing individual inputs and potentially clashing of messages and that sort of thing. So hopefully that answers that question. But yeah, I don't know of anything outside of a rehab setting that would necessarily collate everyone into one nice little package, unfortunately.
Because you'll definitely have lots of different treaters still if that's necessary, and that's, I suppose, part and parcel of it. But like Scott said, we as an occupational rehab provider can help collaborate that and collate that to make sure everyone's communicating with each other so that the same person doesn't have to go and explain their story 5 different times. They're being told one bit of education that might counteract another bit of education from another provider. So we can attend those treatment updates, those sessions with them and help make the information make sense.
All right, fantastic. So thank you to our presenters today, Scott Bunton and Alicia Bishop, both from IPAR, for their webinar, Evidence-Based Non-Surgical Management of Persistent Pain in Workers' Compensation, New Trends and Technologies. This webinar was run as part of WorkSafe Tasmania Month. WorkSafe Tasmania Month runs throughout October. Please head to worksafe.tas.gov.au to see what other webinars and in-person events we are running around the state. Today's webinar was recorded and will be made available after WorkSafe Month on WorkSafe Tasmania's YouTube page. Those who attended today will also receive a survey. We do appreciate you providing us with your feedback. So again, thank you to our presenters, Alicia and Scott from IPAR. Thank you to everyone for attending, and have a safe and healthy day. Thank you.